So my name is Ben Muir, one of the founders of the Plantar. I'm a physio. I've been in private practice now for about 12 years, mainly across Asia, doing rugby stuff. So a lot of pitch side and private practice and stuff like the HSBC sevens. And I worked for World Rugby for a bit, doing medical education, first aid stuff and things like that. Great. Okay, so moving on quickly, enough about me. So just from, one sec. So just going straight into my presentation. So first of all, a massive thank you again to the NHS for all your hard work in these times. And you know, obviously we've got a lot of podiatrists on here who are returning to practice in this time. So it's obviously extremely challenging times at the moment. And we, you know, all under a lot of pressure at the minute with safety and things like that. So big thank you to everyone who's doing their shift and putting in the effort at the moment. It's not easy at all. So basically, yeah, we're going to be talking about the plantar fascia loading. So obviously looking at different studies across the entire body and how that relates to the plantar fascia and what evidence we have for fascia loading as well. At the moment, obviously this is sponsored by the Plantar Pad, so I'm going to give you the hard sale on that and tell you how amazing it is. So bear with me on that a little bit. So yeah, moving on quickly. So obviously you guys are all familiar with plantar fascia injuries. And we know that there's a lifetime prevalence of 10%, so 1 in 10 people are going to get plantar fasciopathy, plantar fasciitis in their lifetime. Sorry, I'm going to switch between terms a little bit. Obviously there's some controversy about what we are calling it. I've called it plantar fasciopathy until recently, but obviously there's more and more evidence suggesting that there is a chronic inflammation present there. So, you know, plantar fasciitis is coming back in, and there's a big push from the Scandinavian crowd talking about plantar heel pain as a more general, maybe a more appropriate term for it, because we don't know exactly why people get pain. We're not 100% clued up on the histology of how it relates to pain output. So that's their argument really for plantar heel pain as a more general term. So yeah, it accounts for 8% of running injuries. There's studies to suggest that it can probably be up to 12% of running injuries. So a huge prevalence in our athletic population, recreational runners and athletes, you know, to the elite level. So it can affect everyone, you know, everyone really. And obviously your sedentary person is likely to get it too, particularly if they're, you know, changing their activity levels. You know, around these times, I think it's probably been really prevalent in people walking more, getting that hour a day, actually getting some structured exercise into their routine and maybe being off work and having the opportunity to do that. 50% of specialist referrals have pain up to 10 years. I mean, if you're seeing a specialist with plantar fasciopathy, you've probably had it for a long time anyway to get that far down the pathway. So, you know, it is a chronic condition. We see that it lasts a long time. If someone has been suffering with plantar fasciopathy for more than 3 months, they have an 80.5% chance of having it after a year, 50% after 5 years, and then 45.6% after 10 years. This is a longitudinal study that's recently been done. And it's, you know, shows how chronic this condition can be, and actually it probably doesn't follow such a natural timeline as we initially thought in a lot of the population. Obviously there's a lot of risk factors involved in that, huge variation in the population that are probably being looked at in this study, but yeah, it's definitely a chronic issue which affects a lot of people. So the effect on the individual, you know, there's a study that's recently been done that shows greater levels of depression, stress, anxiety, and fear of movement, kinesiophobia in people specifically with plantar fasciopathy. So this, we knew in other populations such as patellofemoral pain and things like this, lower back pain, but definitely associated with plantar fasciopathy as well. So we've got to be careful with these people, how we're talking to them, and trying to get them, managing their condition early and getting them back to function as quickly as we can. So yeah, it has a big stress on mental health as well, which we've always got to take into consideration with MSK people, patients. There's limitation, obviously, as I was saying, in mobility and quality of life for a lot of these people, which is definitely a factor we need to take into consideration. And always when treating people with MSK issues, you're taking into account a holistic approach. So 70% of people with depression only report MSK symptoms. So that's a huge consideration when you're treating anyone with musculoskeletal issues. You've got to look at the whole picture and relate to that person quickly too, just to try and get them on board. Between 6 and 20% of people. It took 3 months off work, which obviously in our current situation doesn't seem like a big deal. But this was, massive. It could be a massive detriment on the workforce as well, particularly with your nurses, your policemen, these people who are on their feet a lot and have a lot of physical demand in their role, and a lot of pressure going through the plantar fascia. It's very important to consider that and what they do for work. So the holistic approach, we don't treat painful heels, we treat people with painful heels. So we're putting the person first, obviously, before their diagnosis, and getting to know this person, figuring out their goals, figuring out their start point and their end point. Everyone's going to be slightly different in that. So it's building that rapport is so important, and getting them on board with how we can help and how to get them out of pain. And a great quote from Oliver Sacks, the late Oliver Sacks, that summarizes that very nicely. So the histology, getting into the deep end pretty quickly. So basically, in a nutshell, we're still investigating. We don't know fully the histology. We haven't done enough studies on this, actually, which is really interesting. But there's been other studies done more in depth on hamstring tendons and Achilles tendons, which kind of show us probably more information than we know about the plantar fascia in particular. There hasn't been many biopsy studies done on plantar fasciopathy. But obviously what we tend to see is degenerative changes of the plantar fascia enthesis. So, that's where we see localized bone edema, fibrillation, thickening of tissue, other things going on around there. So basically what we think that is down to is an imbalance in collagen synthesis and degradation, and which causes the cell disorganization. So I'll go into that a bit later. Elevation in cytokines. You see this in all tendinopathies. Cytokine is a protein that's excreted by your immune system, by your immune cells. It doesn't necessarily mean that there's inflammation there, but it's part of the immune system. So there's some healing going on, or there's healing trying to happen at that point. Ground substance, increased kind of extracellular substances. So ground substance is kind of like a gel type structure, which helps the tissues communicate between each other, particularly when mechanical forces are going through them. Increased fibroblast proliferation. That's fibroblasts are cells that are designed to build up proteins. In this case, particularly collagen. Looking at your tenocytes, your tenoblasts, this is what they're there for. So with a tenopathic tissue, or this the plantar fascia, plantar fasciopathy, plantar fasciitis, you see an increased proliferation of these cells. So they're obviously trying to lay down good, healthy structures around the injured tissue. And again, with all of these things, we see increased vascularity and substance P. So increased substance P is one of the theories to why this can become painful. Substance P is a neurotransmitter, so maybe has an effect on your nociceptors around that area. However, there's not many nociceptors actually deep in the tendon tissue. It's more around surrounding that tissue. So when someone is getting pain, we think that it's more the tip of the iceberg, that they probably had a lot of degenerative changes for a while, things going on in that tendon and that structure. And then they start getting pain a bit further down the line once these structures become more prolific, I don't know, on the outside of that structure. So there's this study done in 2018 is the study I was talking about, where we're looking at Achilles tendons and hamstring tendons, and this study kind of showed that there was a chronic immune response going on. So evidence that there's inflammation at these sites. So hence why fasciitis has kind of come back in as maybe a correct term, as opposed to fasciopathy. But I think, the jury's still out, and maybe plantar heel pain is the most kind of appropriate term to use in these times, as we still 100% don't know. So the pathophysiology, so kind of looking at the whole structure. So when you ultrasound someone with plantar fasciitis, plantar fasciopathy, they're 105 times more likely. It's pretty significant to have a more than 4 millimeter thickness compared to a control group. So those with no pain. And up to 50% of those have an inferior calcaneal spur. But we don't know how that relates to pain, really. Like, a lot of people are walking around with calcaneal spurs and they don't know. So it doesn't seem to be a good indicator of pain. And that's why you're probably seeing less and less people going for surgery with calcaneal spurs. And also, there's bone edema is very common. And as I was saying, this is probably one of the causes of pain as well. It can be quite a sensitive area. That enthesis and maybe having that swelling around that point. And that's particularly what people describe as that kind of stabbing sensation, which is probably that localized area of pain that they're getting. That's kind of what I was saying, that there's an unpredictability in terms of thickening of tissue, calcaneal spurs and pain. So scanning these people, looking at the thickening, the tendon definitely tells a story. It tells you what this person has done, if their tendon has adapted and changed due to forces and pressure and what they're doing with it. But it doesn't give you a clear indicator of how many people, if this person is in pain or not. So obviously your pain level is an output of the brain. Your nociception is the input, and the brain analyzes that and gives you an output of pain. So, and it sits very close to like your emotional cortex in terms of how it's influenced. So if your patient has increased anxiety about work, about returning to exercise, or they have a tendency to catastrophize, or they're getting less sleep, they're particularly going through a stressful time in their life. All of these things come into play when you're treating any MSK issue and how they can tolerate that pain. Like Greg Lehman obviously talks about filling your cup and then having a pain event. And this is definitely something we need to consider with these people. So asking them those questions about what's going on elsewhere, what might be influencing them, how they're sleeping and things like this, gives us a better picture of how to approach this person, and also how well they may respond or may not respond to, and what they might need to change around not just the physical side of things as well. Possible triggers for plantar fasciopathy. So basically the old theory was mechanical damage, so tearing in the fibrils that didn't really heal properly, which I think is kind of half true. It's not the full story. And Jill Cook seems to think that this is not the case. Obviously she's pretty switched on with her tendons. So she seems to think that it's almost impossible to have micro tears in a really healthy collagen tissue. So there's probably more degeneration going on before this occurs, or an imbalance in formation of structures and breakdown of structures, and maybe some slight disorganization in the structure as well before this really flares up. So this kind of takes us into this, like, it could be the main driver of actually understimulation and then increased stimulation very quickly, which would lead to flare-ups of pain, you know, more likely to cause an inflammation on a cellular level, which is what I come on to next. And, you know, this is a big thing with runners as well. People who are pushing hard, training for those marathons, those long runs, or really picking up their pace over a certain distance, or suddenly deciding that they want to run hills and trails and things like this. That quick change in stimulus is obviously going to challenge the plantar fascia in a different way that it's probably not orientated to, and probably break it down in that sense, irritate it, cause some cellular changes on that level. Yes, and this is kind of what we're talking about, like an imbalance in catabolic and anabolic process, leading to cells just, you know, haphazardly laying down because they're not actually getting the time to lay down in a linear way. You're just, again, stressing again and again and again without leaving enough time for the natural healing process to take place, which is a big consideration when you're trying to build people up and pace them when they're returning to exercise as well. So they think there's obviously secondary things that happen. So increased nerve growth, we see that across the lower limb as well with tendinopathies, which may be like an adaptation in nociceptors and structures around the tendon, which may suggest why people have chronic issues. And once they get past that, you know, 2-3 year period of having this issue, why it's so hard for them to get better after that, because obviously the healing process takes place in a relatively short period of time compared to like 2-3 years. You know, by that time, you know, there's going to be big changes in that tissue and it's going to struggle to properly heal at that. So yeah, loss of tissue homeostasis. So we're talking about hormonal changes. Obviously, this is a really common issue with women going through menopause, and maybe those changes in estrogen levels are a big part of why. And changing, you know, estrogen is a really good protector of tendons. And apoptosis is like the natural programming of the cell, like when it's due to kind of die off and be replaced. So it's that natural death of the cell. Great word, but basically why that's relevant is maybe that you're getting more apoptosis than you are getting cell formation, and that leads to an imbalance as well, which can be in this homeostasis point of view, but also that definitely relates to people who are sedentary and not loading enough or not using it enough, not stimulating growth of that tissue and adaptation to what they do. So it's a really important part of tendinopathies as well. So we're treating the donut, not the hole. So gotta love a donut now and again. And basically the donut represents the healthy tissue kind of around the injury, and the hole represents the injury itself. So this model again is come from Jill Cook and Docking. And what this is suggesting is that actually the healthy tissue grows and responds, but the injured tissue doesn't change very much at all. So this is what we're talking about, that kind of load adaptation. So imagine if you had a rope across the garden that zigzagged all the way across, and you're trying to pull on one side to get the other, you know, whatever is tied to the other side of the rope to move. It's going to be really inefficient. You're not going to get any traction on that at all. Whereas if you had a nice taut rope that you're pulling on, you're going to see that force translation very quickly. And this is what they're kind of saying, is that actually maybe the hole doesn't respond to load very well because of the disorganized tissue. So you're not going to get any linear pull through that injured tissue. So therefore trying to load it up doesn't really change it. But what does change is the healthy tissue around it and your ability to grow more collagen fibers, more tenocytes around that injured tissue in order to make it a more efficient structure. So yeah, I think I've covered all of that. So yeah, this is a cool study. Docking was looking at Achilles tendinopathies, and suggesting that actually through ultrasound scans, suggesting that the pathological tendon that had healed had more healthy structure than a healthy Achilles, if that makes sense. So basically the tendon had almost adapted around that scar tissue and made a really thick tissue structure with lots of healthy tissue around the scar to almost overcompensate. So when you're seeing tissue thickening on a scan, it probably means that this person has adapted reasonably well around it. I mean, they may still be in that reactive stage and still be getting pain, but they're probably in the process of laying down new tissue around the scar or the injured structure. So yeah, the Doughnut, so this is what I was talking about, basically disorganized tissue. Basically, it's very hard to get mechanical stimulus to translate through that disorganized tissue. So therefore, it may not change at all. Sorry, yeah, that's what I mean with the whole. So strengthen the Doughnut is my main takeaway point from this, and I'm sure that's memorable. So this obviously comes alongside symptom modification, so looking at whatever you can. I know a lot of podiatrists use shockwave therapy to modify the nervous system, calm that pain down, which has been proven to be really effective. So, but it doesn't actually stimulate the recovery of laying down at the tenocytes. So it's a good thing to use to get them out of that reactive stage and manage pain. But you also need to be using it in combination with some kind of loading to build up the structure around the injured tissue as well. So yeah, exercising is really important anyway, so obviously looking at motor inhibition in muscles around painful tissue. So obviously the nervous system is pretty amazing at not facilitating muscles that are attached to things that may cause pain. So this so basically you're trying to reduce motor inhibition as quickly as you can. Reduce strength losses, so you don't want this particularly with anyone really, but particularly with your athletes, you don't want them getting atrophy or decreasing their load capacity in other tissues around that. So you're looking at that whole kinetic chain, keeping them as strong as possible in other areas around the foot and ankle, quad, hamstring, glutes, even looking at their lower back, getting them doing more compound movements as well is really important. The need to reconsider treatment. Obviously, there's always needs to review what we do and how we approach things. So this Hansen study, again, going back to that, 40% of patients in this trial still had symptoms after 2 years after specific plantar fascia stretching and wearing insoles. I mean, that's probably not surprising. But, there's a huge variation in that, isn't there, in terms of who's prescribing that insole, why, where it's from, the quality of that, and how they're stretching, how regularly, what their coherence is. But it's still something that I think the loading is something that we tend not to do, or have only really introduced in recent years. So these studies don't really engulf that, but there's definitely an argument that we need to try something new, try something different, try an adjunct therapy, which is probably going to be effective in the long term as well. There's a weak association with static foot posture and hypermobility. I get sent patients a lot that, they've been told that they have flat feet and that's why they have pain. Maybe there's a weak association there, but there doesn't seem to be anything too set in stone with that. People are massively adaptable, but looking at the more functionally moving is way more important. Like if they're the speed of their pronation, these type of things, if they're putting more force through that plantar fascia than they need to be with their running style, obviously this is where your sports podiatrist comes in, like looking at how they're moving around that foot and ankle, how to decrease those forces, how to offload it, how to strengthen is really, really important. So this is what we've already said: cortisone injection, shockwave therapy, good short-term effects, but poor long-term outcomes. I mean, they kind of, I think it's still really valid. Both of these treatments are really important to get people moving early. And of course, you're going to have better long-term effects if you're getting this person moving early, and you're not going to have so much reduced strength in the kinetic chain. They're going to get back to function early. They're probably going to, avoid taking time off work, and having all those quality of life impacts as well. So basically, the reason why I guess we studied heavy slow resistance training is looking at its effects in other areas in the body. So it's been shown to be really effective with patellar tendons, Achilles tendons, rotator cuff issues, and really great, effects of that. And that's kind of the main focus with those issues. But we hadn't really considered it much before Ratliff in 2015 did this high load strength training, which showed in that study to have really good midterm effects. I was listening to him recently saying that, basically the 3-month period, there was a really significant difference in the foot function index between people just stretching compared to the high load strength training. But obviously those in the study, those results kind of diminished as we got to more of a year mark. But he felt that people just became less coherent with the exercise as soon as they got back to a good functional level. They just stopped doing it, which is a really important lesson from that study. I think it obviously shows really good midterm effects. But it's trying to keep it interesting, make it easy for people, and keep them going long term with that exercise. Even if it's a few times a week, they're going to continue to have positive effects from that. So obviously other factors that contribute to prevalence of plantar fasciopathy, BMI, that always comes up as the main one actually. So we're looking to obviously educate the patients. It's always a really tough conversation. I hate that one and avoid it. I must admit, but if this is an obvious issue, then using MDT, talking to dietitians, nutritionists, getting these people considering that, or even just planting that seed, using your motivational interviewing techniques to let them come to that conclusion as well is a good way. But some people need more prompting, more assistance in that as well, and that might be down to mental health issues as well, which we need to take into consideration and refer appropriately. Load management, obviously, with your athletes or your sedentary people, talking to them about that, giving them a clear plan of how to build up, or maybe easing them off again and then slowly building them back up is really, really important to give them the self-efficacy to kind of get onto these modalities and manage it themselves, which is so important. So like your great toe, MTP joint extension, there's mixed results. There's a few studies that suggest that this isn't relevant. There's a few that do, so it's a bit of a mixed bag with that one. But I think, I consider it an important thing, particularly with your runners who are trying to actually get that plantar fascia loaded efficiently. And so that's a really key one. Dorsiflexion range of motion, it comes up again and again, and this seems to be very relevant with plantar fasciopathy as well. So getting that ankle mobilized, stretching it out, whatever you can do. Ankle eversion strength is actually something I'd never considered before reading this study, but it kind of makes a lot of sense. Just having that eversion so you're not, pronating so quickly over that ankle is a really key one. So they're looking at the ratio between inversion and eversion strength. And that was clear that having a strong everters was really important in the recovery. In actually getting plantar fasciopathy. Toe flexor strength is another one. Your toe flexors being strong protects the plantar fascia, helps you take the load off a little bit. Hamstring tension, again, something that I probably wouldn't test so much on people who came in with a foot issue, and that's something that I think I definitely need to reconsider in my practice, looking at the whole kinetic chain, checking out their straight leg raise, and that might be a sign of adaptive changes. people trying to offload, keep that hamstring tight, or it could be that there's general weakness in that lower limb. So maybe their hamstring is a little bit weak, therefore prone to be a bit tighter. Tibialis posterior strength, so tib post, again, really relevant thing to train. And there's a number of exercises obviously to do for that, to offload it. And obviously looking at running styles, there's studies, this Ribeiro study looked at people running and how much pressure they're putting through the plantar fascia. And he found that obviously people with like acute plantar fasciopathy tended to offload their plantar fascia quite effectively. So getting that painful stimulus, worked for them to offload it. And then the more chronic people, interestingly enough, had much higher loads going through their plantar fascia. So these are things that we need to change. We need to obviously modify their running style or offload them in some way with shoe prescription or orthotics if possible, and that's where you podiatrists are excellent at. So why load? So you kind of, obviously I've talked about the physiology of it a little bit, but isotonic and eccentric exercises show good outcomes in the lower limb and upper limb. So people always used to talk about eccentrics, like how important eccentrics are, but it doesn't seem to matter, and particularly with the plantar fascia as well. It's a non-contractile tissue. Obviously, it's linked to calf and Achilles tension, but it doesn't. See, there's no muscle attachment in the plantar fascia, so it means that doing these things, all it's about is putting load through it. You don't have to do it in a certain way, but getting as much load through it as you can tolerate is really the key. So basically I'm just saying there that it's similar to a tendinopathy. So this is a cool study done on AFL players by Docking. He looked at Achilles structures and ultrasounded them pre-season and looked at the tissue integrity through that pre-season training. I think it was a couple of months, like 2 to 3 months. It's quite a long pre-training. And basically what he found was that the tissue integrity actually improved as they went through their training. So obviously this tissue is responding really well to different loads. And that's important to know as well, so it doesn't have to be, once you get them functional again, actually getting them back to running can be beneficial because they're going to adapt to that, and the tissue is going to modify to the stresses that they're putting through it. And that's a really important thing with plantar fasciopathy that we don't really consider. The high load strength training is really good for the adaptation in the collagen and laying down tissue. But if you've got a runner, you've got to move them a step on from that and get them absorbing, reactive forces, jumping, landing in various ways, hopping and bounding and things to almost push their threshold that much further, so they're not going to irritate it on their 5K run. As good as the high load strength training is, you've also got to basically build up the tissue's capacity to absorb and release tension as it's designed to do. Loading shows increased matrix turnover in tenocytes. This was and maybe early healing processes in tenopathic cells. So with this one, they suspended tenocytes and put some under pressure, and some they just left as a control group. And then they were looking at the genetic signaling after the study, and they saw that the tenocytes, they kind of continuously loaded them for 24 hours, and they showed that they had much more healing properties and responses going on. The structure was much better. So again, it's just all pointing back to how important loading is in the tenocyte formation and laying down the architecture in the right way. And again, we're going back to that Rathliff study, talking about pain and function, good improvements in that. Mainly in pain, actually people reduced their pain quite significantly on the foot function index, and their perceived improvement was a lot better than people who were just stretching. Basically offloading, if you've got someone with a really reactive plantar fascia, you don't want to load them up straight away. You've got to allow them time to calm that down. So not offloading for too long, though at the same time. So you've got to find that balance between the ripe and the ruin, just making sure that they're not losing strength, they're not losing tissue, low capacity, but they're also calming it down enough. And again, obviously your adjunct therapies, your shockwave, these type of things are really going to help them through that. What we're trying to avoid is the kinetic chain deterioration, and the nervous system changes as well. And the strength of the tissue will only be as good as the load applied on it. So we're really trying to build these people up to high loads, particularly if they're athletes, trying to get them, loaded up with backpacks on when doing the exercise, to replicate as much force as we can. Because obviously they're under large amounts of stress if they're sprinters or jumpers, basketball players, rugby players, these type of patients that we see. So how the exercise works. So basically it utilizes the windlass mechanism, and it basically goes back to this study done by Carlson in 2000. So Carlson had cadavers that he was using and pulling force through their Achilles tendon and measuring the strain through the plantar fascia. And basically he was going up, so you can see the graph hopefully in that top right. He was going up to 45 degrees, and so this was 500 newtons, so roughly 50 kg, and 45 degree dorsiflexion of the MTP, basically push the stress through the tendon by more than 60%. Well, around 50 to 60, sorry, not more than 60. But you can see that, this is someone doing a normal heel raise, the 0 degrees. So up to 45 degrees, you see a significant increase in that tensile load through the plantar fascia. And that's what we're trying to achieve to gain, again, that healing process at the enthesis in particular. So basically our product, you can see here at the bottom, the plantar pad was based on this study. They used a rolled up towel, obviously, but over the years I've found that patients are not coherent to that. It slips around, they get frustrated with it and don't do it for a particularly long time because of that. So we developed this really simple, cheap mechanism which helps them to do it, helps kind of the patients to be coherent, just makes it as easy as possible, which I'll come to in a second. So Mechanics of Mechanotherapy. So it activates transduction, which is kind of the communication of force between the cells. Puts force through the cellular matrix, gets that communicating with the cells as well. It influences the anabolic response. So it kind of helps, again, the tissue to build up and strengthen. It's associated with more normal structural changes in the tenocytes and the extracellular matrix, increased matrix turnover, and de novo synthesis. So de novo synthesis is basically the build-up of cells, fresh cells from like nutrients in our system rather than recycling old cells. It doesn't seem to matter if the load is, concentric, eccentric. The most important thing is time under tension and also the weight of that load. So when to load, obviously identifying aggravating factors is really important. Getting this person to offload those aggravating factors. It may be that they're moving in a certain way, doing something in their daily routine which is irritating it, or just training too hard and not allowing enough time to respond. So as in not healing properly before their next training session. So basically we want to offload for as short a period as possible, and again, use your modalities at this point, get them back to exercise as quickly as possible, but we're monitoring their 24-hour pattern. So looking at how they're responding in the morning, obviously that's a clear indicator, clear kind of attribute of plantar fasciopathy is that morning pain first thing that tends to ease off as they they get going. You want them monitoring that. You don't want that flaring up too much, because that's suggestive of actually the tissue breaking down or inflaming, becoming more irritated at that point. So, you're taking small steps to build them back up, basically, and then allowing a good period of healing before then you're loading them up again. So the only exercise that you really progress from is the one that you recover from. So you've got to bear that in mind. Educating your patients about pain. So trying to reassure them that actually, this pain doesn't necessarily relate to the amount of damage that they have. It can be really, really painful, really sensitive. And that's mainly down to, this inflammatory reactive stage. It doesn't mean that they've, ripped something off or they've injured something. Plus, you're kind of trying to calm them down about that, or monitoring their pain a bit. So educating them that a little bit of pain is actually okay. It means that you're probably doing the right thing, that you're loading it in a way that is stimulating recovery. So I always tell people 3 or 4 out of 10 on the VAS scale is a good measure. That means that you're probably doing the right thing. But then monitoring these periods where they're offloaded for a while and then up and moving again, that tends to be when you start to get the most pain in the plantar fascia. And all this education promotes self-efficacy, gives them a sense of control, helps them to figure out how to manage this themselves as well, and manage, when they may be in a reactive stage, what they need to do. So yeah, great quote from Greg Lehman there, which I've edited a bit. And then this is from Cook and Docking, this, building up your capacity. Then energy storage, something that we talked about with runners, jumping, hopping. So it's more, with this is more kind of landing type exercises. So you might get them hopping off their good foot onto their bad and landing there. And then the storage and release would be your next progression. So then kind of bounding on that leg, doing box jumps, step ups, quick step ups, that type of thing would be great. And then getting them back to their activity. So clinical application. So we've just gone through the offloading. So mainly training every other day with this is really important. With tendon structures, particularly in the lower limb, it's shown that it takes 48 hours to recover fully. So I would get them doing these exercises every other day. They don't, which is always music to your patients' ears, that they don't have to do them 3 times a day. Do them well every other day. That's the clear message. And aiming to get them doing 12 reps of 4 sets, 1 minute rest to start with. So 12 rep max, they should be kind of fatiguing at that 12 rep point. If they're not, then put a backpack on them, stick some books in there, increase the load. So you want to find where their 12 rep max is. Obviously that's going to be totally different to everyone, and some people may not be able to achieve 12 reps initially. And they may need to be offloaded. So that's when you're doing a double leg heel raise instead of a single. Or you can see a few variations that I've done on our Instagram page of, a foot on a step, or you're in a lunge and doing a soleus raise, or even a seated soleus raise, just to load the plantar fascia in any way you possibly can. That's hopefully just below their threshold to flare up, but gets them moving early. That's really important. So again, this is kind of following Raflif's guidance of 4 weeks. He moved to 8 rep max, so really getting some weight through them then. And at this point, he had like 10 kg in the backpack and getting them pushing load through. So obviously this is more for your athletic population, and they tend to cohere more to this, and be more motivated in that way too. So obviously this is keeping you active in other ways, so swimming, cycling, these low levels of impact which go through the plantar fascia, you've got to keep that fitness up. And obviously that speeds up your healing process, just keeping fit and healthy anyway. Working on surrounding muscle groups, obviously massively important. Trying to keep the soleus strong, that is shown to be massively associated with lower limb, Achilles, plantar fascia, tendinopathies. If you have runners, work on their quads, hamstrings, glutes, everything. And then Yeah, so set expectations. This exercise is going to be tough. It might give you a bit of muscle soreness, but that's a good thing. Go through it with them, guide them through it on the first go, so that they're not put off when they're at home. Try and get all those repetitions done in that session, so you can say, yeah, this is what you're meant to feel. This is how it should be, so that they don't do it the first time and then stop straight away. Obviously guiding them, giving them all that information on how to increase load by putting books and things in backpacks. Obviously this is specific to the individual. If you've got a runner, you're probably going to be doing other exercises around this specifically for running. If you've got a basketball player, you want to be doing maybe more ankle focused stuff as well, specific for changing direction and things like that. Self-efficacy, again, this is all leading to that kind of building that confidence and managing it. And actually it's shown to be a really good painkiller. Giving someone that control tends to reduce any kinesiophobia and catastrophizing, and gives them a really good understanding of how that they can control this condition in the future. A great quote from the late Lewis Griffith there. So who's suitable? Are they going to do the exercise? So you probably know your patients quite well, and you know the person who's coming in the door. And if you don't, you get to know them quite quickly. And the best exercise is the one that the person's going to do. So if you've got that person who isn't going to do these heel raises, you're better to give them stretches, basically. And they're still proven to be reasonably effective, but not as effective. The more athletic population respond better. They're going to be more coherent with this. They're probably going to be more used to putting their body through exercise. And obviously differential diagnosis. So you're looking at your neuro issues, your Baxter's nerve, your tarsal tunnel stuff, and fat pad stuff with this. I won't go into that, but podiatrists, you're really key with this, and that's where you guys are so valuable with differential diagnosis with this. And it's so important to get the right diagnosis. I think there's evidence saying that 1 in 10 plantar heel pain patients are actually, maybe a Baxter's nerve or a tarsal tunnel irritation. But obviously there's lots of ways of telling who is and who isn't. Exercise progression, maybe even starting them off with stretches if they can't tolerate the load, getting them doing toe flexion exercises. I'm going to put a few more things on Instagram this week of different exercises that can be used. Double leg heel raises, soleus raises, all these things are really good. Then this is basically, then moving on to eccentrics, then single leg, concentric, isotonic exercises as well. Plantar fascia loading is really important, getting onto that. And then doing the more hopping, jumping, fast loading, which I think is neglected with plantar fascia patients. And that's, really only relevant for your athletic population. So bear that in mind. And returning to activity, this is really important. So the Raffliff was really strict with this. So basically, the patients in the study or his patients, I think, actually, I don't know if they're the ones in the study. This was an interview of him. He was saying that he only allows people to run if they're walking a fast, brisk 10K with no pain at all and no pain the next day, which I would be going mad at. I think I would want to be running much faster than that. But it's a good, clear measure, and it seems to work really well. So if you're having to hold that patient back, that person who's really wanting to get back to running, like your keen distance runners, they don't want to be spending too much time off the road. Setting this as a goal is a really clear indicator for them for when they're ready to get back. I think that's so important too. So couch to 5K is a useful tool. I modify the couch to 5K all the time to the individual, and switch, obviously maybe get them starting at week 3, changing a few of the weeks, but it's a really good blueprint to use with people. And obviously your individual who's used to running is probably going to progress a lot quicker than the couch to 5K. So you've got to bear that in mind as well. Maybe skipping a couple of weeks in between as well, just to build them up faster so they don't lose interest. And obviously all your meaningful activities, if this person has other interests, get them doing that for a while. If they're a keen cyclist, get them on the bike. So yeah, the Plantar pad. So this is our little device. It's like a high quality, high density foam. Really easy way to incorporate high load training. Patients seem to really like it. We're getting tons of good feedback from podiatrists. I think we're in 25 clinics now in the UK. We've been going 6 weeks, so that's really good. And we've been doing this type of stuff and mainly doing Instagram. People have been contacting us through there. So it's been, we've been amazed with the support. Actually, people have really got onto it and seem to really like it. So that's great. So we also get it made locally, just down the road from me. I'm in Oakham in the middle of England, and is basically we've designed it and got it made locally. So we're cutting down on our carbon footprint and everything else, and we're really conscious of that with our postage and packaging and things. So yeah, it's easy and consistent. It's evidence-based, more effective than stretching. Yeah, it definitely helps to improve coherence. And it's well priced. So basically it comes with a workout plan. This is, so we've got a few exercises that come as a hard copy with each pad. So, and they may help to progress the patient initially. So stretching, getting tibialis anterior strong, isometric toe flexors, this type of thing. So that comes with each one. And we also now provide an Excel sheet, which is really good, which Julian modified. You can see this is, so this is my co-founder here. This is his foot. He's done the Excel sheet. That's, that's definitely his forte. And it tracks your progress on the foot function index and maps out your progress. One of the hardest things with people is keeping them coherent and also showing to them that they are improving, because improvement to someone might be, I can't stand on my foot, but I want to be running a 5K next week. But any slow progress is actually very, very important with this. So mapping that out for them gives them a really visual thing. So basically they take the foot function index test over the weeks, and that maps out their score and shows them kind of hopefully a linear graph of them progressing. So we're still looking for resellers to make it viable to keep making. So obviously we give good discounts. Our recommended retail price is $12.99, but if you order 10, we sell it to resellers for $7.99, and that goes down to $6.99 if you order a bulk order. And as I was saying, it's in the UK that we make it. And there are our contact details if you want to take a picture of that. That's us. And yeah, we'll obviously talk to you and answer any questions about it. So yeah, a couple of podiatrists who are already stocking it, giving us some feedback. So yeah, a few people who got onto it really early, who contacted us, and from all over the UK and Ireland, which has been amazing to talk to all you people, and I think maybe a few of you are on here. And then here are my references. So that is it. Okay. I hope that was all right. I felt like I was babbling a bit, but I hope that all kind of went all right. Feel free to chat to me if you want to now. Just using the chat box and asking any questions that you have. I may or may not be able to answer them, but I'll give it a go. Thanks, man. Cool. Okay. Hey, that's positive. All right. So yeah, feel free to ask any questions at all. Thanks, man, Mary. That's great. So yeah, if you've got some questions, hang around. If not, go and enjoy a drink. And it's Thursday, right? It's the how long does it last? What do you mean the product, Mary? So I've had some really heavy patients using it. Obviously, talk to them about BMI along the way as well. Yeah. So I've had patients. I weigh like 95 kg on a good day, and I've used one for now 6 months, and it deforms ever so slightly when you're using it, which is a design feature to actually just make it more comfortable. But it still keeps your toes at that 45-degree angle, so you're getting maximum load through the plantar fascia. Then the foam just pops up back into shape within a couple of minutes. So I've used mine, and I'm reasonably heavy for a long time, and it hasn't shifted. So we've really tested it out on that, and I've given it to heavier people than me, and they haven't been able to modify it. I mean, change it permanently. So here's the product here, by the way. I've got one in my hand. So there's the plantar pad there. No, I don't think it's affected by heat. I mean, how hot are we talking? I don't know if you're doing it in a sauna, it might. I don't know. We've had a hot period, as hot as it gets in the UK recently, and they're not affected at all. It's a really premium quality material. So we're right at the top end of this particular material. So the design is that it won't be affected. You know, if you took a flame to it, it probably would be, but not not in your normal atmosphere, or if you weren't doing anything silly with it. The slides, yeah. So what I'm going to do is put this on YouTube if it's a decent version, and then I'll send you all a version of this. So if you wanted to share it with colleagues and stuff, I'll just take a few days to edit it and basically send it out to you. Any more questions at all? So I'm trying to think of any more info. So an interesting study that was done. There's a good study coming up next year. Rael and Raflif are looking at cortisone injections with plantar fascia loading compared to plantar fascia loading, doing the same thing. And I've been in contact with him, with Raflif, and said that we're happy to give them the product for them to test it. So they're discussing that right now, which is pretty cool. So hopefully we're in that study. Who knows? But yeah, they're looking at that trial and just seeing if there's any relevance in obviously getting the cortisone. Yeah, totally, Mary. So it behaves very much like a tendon in the way that it responds to load. So it absorbs load and releases it, and that's exactly what our tendons are designed to do. So you see someone like Usain Bolt has massively long Achilles tendons, so you can almost spring off his lower leg. And the fascia responds in a very similar way. It absorbs tension and releases it. So it acts as like a spring. And obviously using the windlass mechanism, you almost bounce off it when you're running a little bit. So it's a really good shock absorber. So what we're seeing is that it responds to rehab in exactly the same way. So putting a tensile force through it stimulates the healing process and stimulates tenocytes being laid down in a good architecture, good anatomy, which is very relevant for recovering from this issue and having a much stronger plantar fascia in the future. So you're increasing your load capacity so that you're much less likely to flare up again. And it's something that you can do preventatively as well. And we've got a few pro boxers who are using it, which is very cool. One of the podiatrists in Ireland got us onto them. And they're using it with pro athletes at the moment, so that's great. But it's relevant to everyone, but probably at different loads, different exercises are relevant to your individual. So It's obviously it's down to your patient, I think, and this is what we're trying to do is make it more consistent. So we're trying to make it as kind of formatted as possible. Obviously, over the study, they show good results midterm, and then people tend to get lazy with it longer term, and that's where you tend to get these. Yeah, totally right. I think it's very, very similar to the Achilles, and the Achilles is obviously very much associated. Yeah, I love Jill Cook too. She's great. She's if you check out some of Jill Cook's presentations if you haven't. She talks in extensive depth about tendinopathies. Yeah, so she's really interesting. She hasn't looked at the plantar fascia, mainly Achilles and patella tendons, but it's all relevant from what we're seeing to the plantar fascia too. And you can place an order through us. If you just contact us, and I can chat to you some more as well. If you want to chat, just email us and let us know. I've been speaking to podiatrists all over the place recently, so I'm happy to get on the phone and chat to you guys as well about this and what we can do to help and things like that. So please send us an email. Thanks, Mary. That's great. That's really good. So yeah, obviously thank you. Cheers, Mary. All right, enjoy your evening. So yeah, we're trying to keep this as cheap as possible for people. So we're actually, I think you guys, when you sell them in clinic, you make more profit than we do when we sell them to you, but that's the way that we want to sell it. We want to kind of get it across clinics and make it really accessible to podiatrists and make it really accessible to patients as well. There's some products on the market which are ridiculously priced, and we're trying to keep it as cheap as possible for people so that it's more accessible basically. Any more questions? So I think that's our hour. If you want to contact me again, just get in touch and I'll chat to you guys soon.